So first of all, thank you everyone for attending in person and also attending online. It's really our great pleasure to have an international speaker today. My name is Shiraz Marker. I'm, as many of you know, Professor of Upper GI here and Director of the Surgical Trials Unit. I always think it's funny when you have a upper GI surgeon introducing a lower GI surgeon, but it's great to have some shared learning between our specialties. So it's my great honor to invite Professor Spinelli to give our grand rounds this morning. He is Director of the Division of Colorectal Surgery and Director of General Surgery Residency Program and full Professor of Surgery and the lead of the Surgical Innovation Committee at the Humanitas University in Milano, Italy. His training was, he trained in for 2 years, in 2003 to 2005 at the University of Berlin, and later gained his PhD on enhanced recovery protocols in colorectal surgery. He's truly dedicated to the development of innovative strategies in minimally invasive colorectal surgery. Professor Spinelli is Associate Editor at the Diseases of Colon and Rectum and the Journal of Anus, Rectum and Colon, and was Associate Editor of Colorectal Disease from 2014 to 2023. He is a member of the editorial board of the Journal of Crohn's Colitis and Coloproctology. Somewhat extremely impressively, he has authored and co-authored more than 430 public publications with an combined impact factor of more than 3,000, with an H-index of 74. He is current president of the European Society of Coloproctology, ESCP, and fellow of ESA, the European Surgical Association, fellow of the European Board of Surgery, and member of the International Organization for the Study of Inflammatory Bowel Disease. He's also an honorary fellow of the American Society of Colon and Rectal Surgery, an honorary member of the Dutch Colorectal Society, an honorary fellow of the Czech Surgical Society, as well as the Brazilian Digestive Surgical Society. I think it's truly our honor to invite Professor Spinelli. He's a true world-leading expert in surgical management of inflammatory bowel disease, and I'm very happy to give him the podium. Thank you.
So I would really like to thank Shiraz for this very kind introduction and for the invitation, and I would like to share my thanksgiving also to the whole colorectal team, and particularly with Marta, with whom I would like to show you a couple of past pictures. So I've been here in Oxford in the past, and it was already almost 10 years ago. And here there are pictures of the Oxford, some of the Oxford crew at that time, and I would like all to thank for the great support I have been given in times where I really needed that, and Professor Mortensen especially, and also Marta Roll and all the team in the Oxford Colorectal actually gave me a lot of help and support. So thank you very much. I come from Milano, but I work in Rozzano, which is unfortunately a little bit less fancy. It's a suburb in the southern part of the city. It's not very famous for being a nice place, but it has a university campus, international university campus, and a hospital, which in the last 3 years have been nominated according to some determined criteria, including clinical and scientific, as in Italy by the Ministry of Health, as the first hospital of Italy 3 times in a row. So we are working very hard to make this place a center of excellence for the care and for the research. So let's speak about inflammatory bowel disease. When we deal with inflammatory bowel disease, we are dealing with something where we always have two faces. We have two sides. Everything that we do in surgery is reflected into the consequences on medical therapy, and medical therapy, whatever it is been done in that, reflects invariably on surgery. We will speak and we will touch about some of the many controversies that there are in the area of surgery for ulcerative colitis and for Crohn's disease. There are really a lot of issues. We will not face them all because we also have to work a bit in the morning, but I will try to put to the discussion some of the most important ones. For me, in Crohn's disease, many of the unmet needs that we have seen in the previous pictures actually have to do with the problem of recurrence, which is definitely the Achilles heel of Crohn's disease treatment, and this is as much for physicians as it is for surgeons. I really like this slide, which I think it is very informative, and it gives the idea with the famous Mark Lehmann score. It gives the flavor of the issues with Crohn's disease. Crohn's disease is a chronic and relapsing activity, as you see in the curve down there, but it is also associated over the time those flares leave a heritage, which is unfortunately the complications. And stricture and fistula and abscess are many times already present when the disease is diagnosed. So surgery from one side is really efficient because it is the only really 100% remission of the inflammatory activity that we can give to the patient in many situations. But on the other side, this comes to a cost which is increasing what the gastro colleagues call the digestive damage. So the problem with surgery is that very rarely this is a unique masterpiece. Very often this is something that is going to be repeated, as you see from this slide, where you can appreciate that up to 40% of our patients require a second operation within 10 years from the previous one. And this is for the classic manifestation and classical pattern of the ileocecal Crohn's. So the first point I would like to put to the discussion and to your attention is that we are calling recurrence, which is probably a wrong and misleading definition, because at the end of the day, recurrence implies that the Crohn's disease with surgery would disappear and then it recurs, like cancer does. But the problem is that this does not happen, because the disease doesn't have anything to do with the removal of the consequences of the disease itself, which is the aim of surgery, or with the aim of removing the inflammation and therefore to induce remission by surgery. It is not. Therefore, we should change it. We should discuss with the gastroenterologist. I probably will now write something on that, because I think that it is a persisting disease, and therefore calling it recurrent, it gives a negative nuance also to the surgical operation, because it is always something that would be aimed to do something that it doesn't achieve, which is the prolonged well-being without recurrence. So currently and from many years, we are trying to use this very simple strategy to prevent the postoperative recurrence, which is trying to identify the risk factors, and with an endoscopy that is being done earlier and earlier. Now, about 2 or 3 months after surgery, there is already indication to do an endoscopy to see whether the criteria are there, whether the risk factors are there, in order to start eventually an early immunosuppressive and biologic treatment, or instead to decide whether there is nothing there to wait. But can we do, this is our ambition as surgeons, can we do even something before that? That means in the OR. So can surgery actually have an impact on the disease history? So we know from many years from Sir Alexander Williams that localized that the recurrence is actually not at the anastomotic site, as we usually say. It is a juxta-anastomotic recurrence in the neoterminal ileum. And there have been many attempts to try to solve with a different surgical technique this issue. One that I found very interesting as a concept was the one attempted in the early 90s, or in the mid 90s, by the group of Leuven, where they, with the theory that the microbial environment would trigger the postoperative recurrence, they tried to make a new continent valve. The problem, unfortunately, was that the fixation of the valve was an issue, and that the small anastomotic diameter was itself a problem for post-operative course. So there have been many studies trying to address whether the configuration of the anastomosis side to side, end to end, would have would impact on recurrence rates, and basically no real conclusive data from those studies. And I can say that probably the Mount Sinai group of St. Cohen and Robert McLeod in Canada with this randomized clinical trial put, let's say, the end to this discussion, because there was no difference in recurrence rates by according to the type of anastomosis. Then the discussion, when it seemed to be dead, resurrected with Dr. Toru Kono from Japan. He is when he passed away only a few years ago in 2021, and he proposed something that was completely, that was revitalizing the hopes of surgeons to impact on prevention of recurrence. He put together, he described this anastomosis that he called Kono S, with S that was staying there for the word supporting column. Basically, it was stapling. We will see it in a second, the video, but basically it was a stapled transection of the bowel, which then was combined with a kind of a strictureplasty on it, but with this supporting column giving some space of interposition between the anastomosis itself and the mesentery. So this anastomosis can be obviously adapted also to lap-assisted procedure. These are the two ends stapled as described by the technique. This is exactly his technique. So suture threads to reinforce the ends, and then to be put together, to be solidarized with these stitches. And after these, this is a very easy technique, by the way. It looks complicated, but at the end is a very easy technique. And once it is, and once they are solidarized, after taking the margin of 1 centimeter before or after the supporting column, there is an opening, a longitudinal antimesenteric opening of the small and the large bowel, and with these open up to making an opening of 7 centimeters in transverse diameter, not in length, in transverse diameter. There is the closure. As you can see, it's basically a strictureplasty at the moment, at this time, and it will give rise to, as you see from this video, it just gives you exactly the shape that that we see here. It's a very broad and very I would say it looks scary because it seems a lot of stitches, but at the end it's a very safe anastomosis in terms of post-operative results. But the results in terms of recurrence, they were extremely positive when in the hands of Dr. Kono. Here is the first description of the technique, 2011. Then later on, 5 years later, 5 hospitals data from Japan and 1 from the US, which was the group of Alessandro Fichera in Chicago. They reported 98, 100% at 3 years of recurrence-free survival, which was, quite interesting. Actually, it was, for the most, it was surgical recurrence-free, which you don't expect actually to happen at 3 or 5 years. They were also patients that had no infliximab, so quite interesting data, so very promising data, more than one could think. Obviously, number of limitations there, and subsequently, some years ago, there was this very small, monocentric, underpowered randomized clinical trial that actually supposed that there was, actually stated that there was a difference in the short follow-up that was reported with surgical recurrences in the first 1 or 2 years, and endoscopic recurrences that were significantly lower. But unfortunately, those results, what I can tell you, were absolutely not confirmed by the preliminary results of a large international trial, which is the one that we are also participating in since 2017, and it is with all of those institutions, and where the preliminary results that were presented at ECHO and then submitted for next year, up to 2 years of follow-up, unfortunately lowered significantly every enthusiasm on this technique, because there was zero difference in terms of endoscopic, clinical, or clearly surgical recurrence. So the question for debate is still interesting, and here it's another point. It's the second point I would like to raise today, which is, are outcome measures actually really objective? When we take for a trial that aims to establish the rates of recurrence after Crohn's disease, and we know that there are several levels of recurrences, right? There is the immunologic recurrence, there is the clinical recurrence, there is the endoscopic, the clinical, and the surgical recurrence. So it's a stepwise recurrence model. But when we consider each of those, how do we do it? For example, with endoscopic recurrence based on the ulcers according to the Rutgers description. Is it something that is really reliable? And even surgery, when we think, okay, but surgery is an objective outcome measure, either one is operated or not, sure. But consider that the indication for surgery in these patients is extremely subjective, and it can be really postponed or anticipated according to several factors that are not necessarily making this an objective measure. So this is not something that we usually think about. So regarding the endoscopic outcome measures, there start to be several studies that question the value of the inter-rater reliability of the studies, and therefore there is also one quite recent report that says that the inter-rater variability is even lower than what was reported in this Marteau study from on JCC 2016, and it is interesting because that would have led to incorrect therapeutic decision, for example, regarding the use or not of biologic therapy according to the risk here in 10%, but according to this new data to a higher percent of proportion of patients. So I think that this is something we are willing to look at, and with Willem Bemelman and the group of Amsterdam and San Raffaele Hospital as well in Milano, we are doing a study which is called Hand to Hand, which is basically trying to see whether the impact of the adaptation of the mucosa and submucosa, which is completely different in a hand-sewn anastomosis from stapled anastomosis. With stapled anastomosis, there is no real adaptation mucosa to mucosa, because the staples, they squeeze together the tissue from outside to inside, and the way by which this healing is seen and reported by the endoscopist, it is different whether the anastomosis is done by manual or by stapled anastomosis. So this is what is coming out from this. And this would potentially, with a lot of stapled anastomosis, would potentially lead to a clear overscoring that would then lead to many more patients being treated for, as high-risk patients, while maybe they are not really high risk. So now there is a lot of studies trying to look at that, and this is our randomized trial that we are running right now. As you know, the other topic that was very debated and controversial was the role of the mesentery. So that all started from some theories at the beginning of like 15 years ago, in which the traditional model in which the inflammation in Crohn's disease starts in the lumen, in the mucosa, there the damage then leads to the disruption of the barrier, and therefore to the migration of pathogens within, and then leads as a last consequence to the thickening of the mesentery as a consequence of the inflammation. It was basically completely changed by saying that potentially that was the last damage, the mucosal one, while the disease and the inflammation was rising completely from the mesum. So according to this, the study from Calvin Coffey. I was reviewer for this study in 2018, and it had a lot of limitations that you see here in the boxes. But still, even with all of these limitations, that was an interesting study because it was thought-provoking, it was re-challenging, something that we really didn't even anymore looked at, which was the potential role of the mesentery. So after these, obviously better data have been evoked, especially because the potential, before including into the guidelines something that would need or would push surgeons to do, even in very thickened mesenteries, a dissection that goes very central and therefore potentially putting at risk higher proportion of bowel, that was important. So there were a number of trials that were proposed to look at specifically the role of the mesentery, and also the UK trial, the Merca trial, was combining, by the way, a randomized design for both the mesenteric excision and the anastomosis and the Cono-S anastomosis. But in the meanwhile, the SPICY trial from Amsterdam came out, and this study, very recent publication, unfortunately, was absolutely not seeing any difference in the patients that have been, after a proper randomization and the proper power size calculation, didn't really see any effect of the mesentery. So that, this can be defined that 2024 probably was a year in which both the theories, the major theories of surgical prevention of recurrences went very much down. So other attempts have been made, for example, by the group of Andre Dore, who did a very, this is a very challenging operation for longer than 20 centimeters of ileocecal stricture, an over-the-valve strictureplasty, but with actually very good results, we can say, because it was a very decent post-operative results. But what I think it is really interesting, and he himself and they all intend this more in this sense, this model more into a research model rather than a really clinical model of treatment, because it's not really something that we would think it is good for every patient or every hospital. But it is an incredible model for the study of recurrence, because we have, a diseased with a non-diseased segment that can be easily scoped then later on to see the evolution of the disease without removing it. So it is interesting to see that they reported, as much as it was reported by many strictureplasty studies, the complete regression of inflammation and the bowel wall thickness later on. And this is interesting because, removing the obstacle, mechanical obstacle, it seems to induce a way of healing the bowel itself. And this is exactly the same report that have been made for strictureplasties, for other strictureplasties. So these are the long terms, which are also good. So a further interesting aspect is to try to see whether in Crohn's disease the complications, which is something that we can impact on for sure in Crohn's disease, and whether these could be related with some recurrence, higher risk. And that's why we did with Leuven together an analysis of our studies last year, in which we found a significant impact of post-operative complication on endoscopic, clinical, and surgical recurrence. So quite interesting data, because why is it that interesting? Because it's apart from optimization needs and so on, but it is also a very strong message towards centralization of IBD surgery. Even easy IBD surgery like ileocecal can get, according to the rate of complication, can get an impact on where they are operated on the future recurrence rate. So let's go to UC. In UC, we know that there are different operations, reconstructive, non-reconstructive. We all probably, I spoke to some UK colleagues, and they are all reporting that the rate of pouch surgery, even in centers referral centers like Oxford is, or other very famous centers, they report that the patients are less and less willing to undergo a pouch surgery than it was, let's say, 10 years ago or 20 years ago. Why this? There are probably a number of reasons. One is that even with all the, the technology and technological advantages that we have and efforts that we have put into that, it's still a very challenging operation, even in best hands. And we say in Italy that, that something, when we say something is like cherries, it means that once you do one, then they come all to you. And complications are like cherries, because once you have in pouch surgery especially, they are never coming along. When pelvic sepsis especially, they can it's the worst, but we also have all the others that are interconnecting one to each other. So it is really, really important to take into account that you really have one and only one chance for having an optimal outcome for your pouch, because the outcomes of any revisional surgery will never be exactly as good as the ones of the primary pouch success. So the focus here again is to prevent complications, and this is related with many keys. The first key is choosing the right patient, because the pouch, as we have said before, it's not an operation for everyone. It needs a very individualized counseling. Not every patient is the same, and please always remember this is a quality of life operation. Therefore, it really is a matter of perspective, the success or not. And therefore, when we speak to patients, we really need to select them properly and potentially to give them the informations that are tailored to their situation specifically. Why do I say this? Because this is a slide, a picture I took at ACPGBI 1 or 2 years ago, where Pete Sager was speaking with Darren Fletcher that he had operated previously for UC. And a patient with like him probably have different expectations. Like, he's a professional, top-level football player, and it is important to let everyone understand that their expectation has to be adjusted, because the success, if we have said that the success is related with their perception of the success, the perception has to be adjusted before, and you will, the patient will reach their goal with and will take the right decision beforehand. So also it has to be always be given an emphasis on the fact that this is not cancer surgery. That means that in the majority of the cases for the reconstruction, we have a fantastic window of opportunity to prehab and optimization. So we can do a lot. We are not obliged to give a pouch to this patient. Motivation being a quality of life operation. We can wait and we can motivate, we can act, and then if there is a real willingness and capacity, it can be done later on, as much as it is the same for a patient that is not in the proper nutritional status. And the second key is also to scrutinize ourselves and seeing if we are the right institution and if we are the right surgeon to do it. First of all, the right surgeon without the right institution for pouch surgery has been demonstrated that it's not the right formula, so it's not a single surgeon effort. It's really something where the know-how has to be there at several levels. And I really like to cite this data from the UK, and please, I do it with a lot of envy, because the UK is publishing that, but it's the same situation in the other countries. So many centers, the majority of the centers, are doing an inadequate number of pouches, and therefore it is clear that there is a correlation that you see clearly here with the number of pouches performed and the outcome of the patient, and not only with the institutional volume, but also with the surgeon volume, because a high volume surgeon has a significantly better outcomes, as you see in the second graph, than a mid or low volume surgeon. Then we also need to speak about the timing of surgery, obviously, and there the controversy, I think it is almost dead, because in UC surgery we have the advantage of being able to treat what has to be treated in emergency as the subtotal, but the reconstruction can be done also when if we are worried about any medication, we can wean off any medication, we have time to optimize, and we can put the operation. So at the moment, we don't see an indication for UC. Obviously, FAP is another story, but for UC, an indication to restorative proctocolectomy without ileostomy, but we see an indication to the so-called modified two-stage, which is avoiding some of the more and more clearly emerging problems related with the ileostomy at the second at pouch construction on the long term. We don't have to discuss a lot, maybe in 2024, about minimally invasive surgery, whether this is a controversy or not, or maybe we should, because actually the paradigm has been shifted, so we are selecting cases for open surgery nowadays, and those cases are really the ones in which a major effort has to be made. So generally, it is now acceptable in the majority of the specialized centers. There is no discussion about the minimal invasiveness of the pouch procedure, but there is in every large volume for pouch center, there are patients that are treated open, and these are the most difficult ones because they usually have had a long path before. So never underestimate the advantage of minimal invasivity for pouch surgery, because obviously this is not only short-term, this is not only body image, but this is lower incisional hernias, lower small bowel obstruction, and similar or increased fertility rate than open procedures. So robotic surgery can be considered a kind of a controversy, because at the moment, what is the value of using the robot, for example, in pouch procedures? There is not a lot of data there, actually really few, and the few are not good. So what we can say just outside of the literature probably is that basically all the centers that I know that are doing robotic pouches in the US, they are not doing robotic pouches, they are doing laparoscopic mobilization of the mesentery, of the root of the mesentery to get the length. They are doing the robot, they are using the robot to do non-oncologic proctectomy, and then they are using either fan steel transection and a double stapled anastomosis of a pouch constructed outside of the body, or they are, or any other hybrid technique. So at the moment, it seems that that it is not really there a potential, not even a potential for an advantage, because we are not using it, not even for half of the procedure. But in the future, maybe with other systems, maybe we can discuss it. For sure, we can discuss it again. Which technique do we have to do? So there are some technologies that have been incorporated that have been given, I think, a good potential for pouch. We started to use these and describe the use first of fluorescence for the perfusion of a pouch after all the maneuvers that are being done for a pouch construction. We know that all the important traditional old school messages for a good pouch construction can be combined whenever we have to decide whether to transect or not a certain vessel to get the length. We can see beforehand whether this will lead or not to a significant compromise of the vascularization of the future pouch. And that was, the first description of with a video of a transanal pouch You see it here. Here we are looking from transanally, and the specimen is removed, in this case, transstomally. And then from below, we go and take the pouch and take it down through the pelvis in order to accommodate it within the levator plane and do the anastomosis at the anal canal, as you see here. That was 2017. That was the first. Then we used we did some studies to try to see whether this was bringing something. We did it together with Geneva, and actually we found in one case an intraoperatively sectorial pouch ischemia. That was the only reported difference from what we would have done without fluorescence. But there are also some successes of IBD surgery, and I think I have a few minutes for that because we are going to need to have some times for questions and answers. But let me say that we still are lacking in general any definition, any comprehensive definition of minimal invasivity. So some people really focus on some technical aspects that are related with that, and somebody like, for example, the lack of additional trocar in single port, the use of robotic movement as a potential use of real minimal invasivity. But in reality, I really believe that the truth here is that when we talk about minimizing a surgical trauma, we really give a lot of, we include a lot of sense in it, and it is all related because the effect goes much beyond what we just define as a surgical trauma. We start with lowering the interference with the body homeostasis, therefore all the inflammatory response, by that the complication, by that the hospital stay, inactivity, disability, but with that also impacting on the fears and anxiety that are related with the surgical operation, which itself has an impact on the body homeostasis more and more. When I say this, I'm not speaking anymore about technical stuff. I will skip directly to another topic, but I'm talking about about the work we have been doing many years ago here with Oxford. When Professor Mortensen was here, we wrote a couple of papers which were looking at the perception of surgery. And this is what I think it's the missing ring there, but there is a ring between the reputation of surgery and the delay by which the patients sometimes are referred to us or are willing to undergo such a difficult path. So before concluding, I would like to cite one technical aspect that I think it is for which I invested a lot, and I think that there are some challenges in pouch surgery that we have, technical challenges that we have concentrated on, but they have an impact. And one is the dissection and the preservation of the nerves. One is the transection that has to be tailored exactly, not to have a too high, but not even too high cuff, but not even to compromise the anal transition zone, and therefore the enhanced post-operative function and the avoidance of cross-stapling, which is itself a real problem for the success of the anastomosis. That's why we used this approach that we call TTSS, which is basically a transanally looking after the dissection of the rectum from above, before transecting, going down, transanally looking exactly on the point in which that we completely master, instead of just stapling minimally invasively from above, where we don't have really a control of the length of the cuff, perpendicularly even transection, and controlling the cuff by that, and then doing a single stapled anastomosis, which is intrinsically, as we know from many data, increasing evidence, it is related with better outcomes. So we described 2018, 2019, this rationale for using it for cancer, but also for pouch surgery. And the FDA came later on, some years later, to say that it is clearly not indicated to put two staple lines crossing each other when there is an alternative, because in every district of the body, this is related with higher leak rates. This is a strong recommendation to the manufacturers and to the surgeons. And we looked at our results for pouch surgery. We compared in this study 42 patients which had a laparoscopic double-stapled pouch with 82 patients that had a laparoscopic single-stapled pouch and in the last years. And as you see here, what we found on a functional prospective evaluation was that urgency and antidiarrheal medication have been significantly different, and the rectal cuff was significantly shorter. So this is the technical aspect of this. We do it usually through the proctectomy through a single port. This is the elongation of the mesentery, reaching test to see if it goes down. Then we take the pouch out from the single port device, which is in the stoma site. Please remember that when we do this, and you try to measure the length, it's not the same as doing it through the funnel steel, so it's much longer. And here it's an intramesorectal proctectomy until down. We go down, and then once we have reached the end of the dissection, we go transanally. You see from these pictures that we are closing the rectum here exactly at the point in which we like to do. We think it is appropriate to do preserving the ATZ. And from the internal view, we see, as much as from the external view, transanal view, we see a controlled transection of the rectal wall. We remove the specimen in this case from there. And then the anastomosis is different from the TATME anastomosis. We can see in these incredible pictures from above to outside. So we are seeing the pelvic floor and the cuff that is being stitched from transanal view. From transanally, we can see it from internally. But you see that the cuff is completely mobile because it has been mobilized from above. And this is the difference with the ATME, where the cuff was completely stuck and you had to mobilize it if you wanted to include the rectal wall alone there. So there are other techniques here. The guys from Imperial and the San Marks are doing something in a way similar, and we are trying to push also for reoperative cases more and more those minimal invasive surgery. Let me just mention that one of the small areas of research that I am more proud about is that we tried to see recently whether there was a correlation, and this is a little bit outside of the box, correlation between anxiety and depression and postoperative surgical outcomes. Interestingly, for the first time, there was a clear, prediction of the postoperative biological, let's say, organic complication from something that is related to the mind. And I think that this is very interesting, especially for the possibility to acting on that in prehabilitation protocols. What we are doing now is trying to perioperatively with textile sensors to measure a number. This is, Shiraz, something that I was telling you yesterday. Not only a number of parameters, also HRV and stress parameters to see how they are evolving through the perioperative course of our patients. So, to conclude, IBD care and challenges are multidisciplinary. We share with all of us taking care of those patients. We share the patient themselves, we share the successes, and we share also the failures. And the failures and successes will affect each other. So thank you very much for the opportunity and for the honor of being here.